Hello everyone, very warm regards. I am Dr. Vikas Singh from India, a consultant cardiologist here at Paras Hospital, Patna, and a fellow of the prestigious American College of Cardiology. First of all, sincere apologies for not being able to make to the third international conference of clinical and experimental cardiology going on at Philadelphia. I was supposed to be a part of amongst you all, but anyhow, the topic that I am going to discuss with you today is what amount of fluid offers maximum benefit for tamponade patients. Now, we all know that fluid therapy as a temporizing measure. Why I am saying temporizing? Because the definitive therapy for cardiac tamponade remains pericardiocentesis. So fluid therapy as a temporizing measure has been known for long. But this recommendation is mostly based on animal studies as well as small human studies. The largest amongst these human studies is by the great Sagrista Saulita. However, the current study that we undertook is a landmark study in the sense that none of the earlier studies ever tried to quantitate this recommendation about how much fluid has to be given. Now, I would like to acknowledge a couple of things before moving ahead. First, this entire concept, this entire idea was that of my guide and mentor, Dr. Sudhanshu Kumar Dwivedi from the prestigious King George's Medical College, Lucknow. And it was his guidance and continuous push that actually led to this study. Second, this study was published last year in the European Heart Journal Acute Cardiovascular Care. And I believe some of you might have just gone through the literature. So let's try to understand the utility of this study. Pericardial tamponade or cardiac tamponade is not something that is uncommon in our part of the world, and I believe that is the case with most of the developing countries. The definitive therapy we all know is pericardiocentesis, but that is unfortunately not always immediately available. So many a times the patient needs to be transported to a nearby center where facilities for pericardiocentesis are available. And it is during this interim period that a need for temporizing measure has been going on. Now, literature says that the most promising temporizing measure is fluid therapy. That's why we went ahead and tried to find out if that is actually the case. Fluid therapy actually works, and if it works, how much fluid has to be given. So how did we go about? We included all patients of 16 years of age or older who had large pericardial effusion and echocardiographic evidence of tamponade. Now, what echocardiographic evidences we looked for? Chamber collapse was most common, then significant respiratory variations across mitral and tricuspid valves, plethoric and dilated IVC. Now, some group of patients were excluded for obvious reasons. Now, the patients who were hemodynamically unstable were excluded because we didn't want to waste any time giving fluid to these patients. Second was the patients who had underlying structural heart disease. Now, someone who had underlying mitral stenosis obviously did not deserve to be fluid overloaded. Similar was the case with dilated cardiomyopathy patients who were also having cardiac tamponade. Now, pregnant females and those undergoing hemodialysis were also excluded due to fear of volume overload. Now, all these patients were taken to the cath lab and intrapericardial access was taken along with a right femoral arterial and venous access. A Swan-Ganj continuous cardiac output catheter was introduced in the pulmonary artery and it was connected to Edwards Life Sciences Vigilance 2 monitor. Now, this worked on the principle of thermodilution and it gave us a measure of cardiac output in real time. So cardiac output, cardiac index, systolic blood pressures, diastolic blood pressure, intrapericardial pressure, all were taken at the baseline. These patients then received intravascular fluid therapy in form of normal saline. So 250 ml of normal saline was given over 5 minutes and all these measures that we had taken at baseline were then retaken. Similarly, it was done for total of 1 liter. Every 250 ml was given for 5 minutes, then measures were taken. Another 250 ml over 5 minutes, measures were taken. So in the end, we had 5 sets of measurements, one at the baseline and then 4 readings each after 250 ml given over 5 minutes. And after this study was over, the entire fluid from pericardial space was drained out. The results that came out were interesting, in fact. A total of 47 patients were seen during the study period, out of which around 28 were included in the study. 19 had to be excluded on the basis of the exclusion criteria that we had put in. Out of these 28 patients, 20 happened to be males, 8 were females. The most common cause of tamponade in our group of patients was tuberculosis or infective in origin. All the patients who were taken in the study exhibited an improvement in the hemodynamic parameters like the cardiac output, cardiac index, systolic and diastolic blood pressures, as well as intrapericardial pressure. Now, when we did the paired analysis that we compared one group with the immediately adjacent group, we found that the significant improvement in hemodynamic parameters, particularly the cardiac output and the systolic blood pressure, occurred till 250 ml of fluid given. And after that, the significance was lost. So that means that if the patient received 250 ml of fluid, there was significant increase from the baseline. When the patient received up to 500 ml of fluid, there was again a significant increase to that point of time. Then there was increase compared to baseline, but not significant increase. The p-value was not significant when it was compared to the level obtained after 500 ml of intravascular fluid. A multivariate analysis was done to find out if there are any favorable markers to predict who are the group of patients who are going to benefit most. So a high resting heart rate, a low systolic blood pressure at presentation, a lower cardiac index at baseline, and a higher intrapericardial pressure. Now these were the 4 predictors that we found out, according to which we could say that, okay, these are the 4 group of patients who are going to benefit most from IV fluid, intravascular fluid therapy. Enjoy your conference. That was all from me.